My name is Takanori Takebe, working at Cincinnati Children's, and I'm working primarily on the GI tract, especially liver or biliary tract. So as everybody is interested in, we are interested in how we can model and study the human developmental process, especially for the 10 months of the gestation period for the hepatobiliary development. So, the pluripotent stem cells is destined to form a teratoma, which is really chaotic tissues formed. But I think we want to sort of arrange or assemble more guide them to make more controlled type of tissues, which we call organoid per se. So there are a couple of considerations we can think about. So I think the first is really important to look at the initial spatial default structures. I think initially working on a single stem cell to form an organoid or anterior tissues, but nowadays I think it's becoming more and more complex, especially with the use of human pluripotent stem cells. For instance, if you look at the tissue boundary model, I think there are brain assembly publishing from the Stanford group to form a forebrain and midbrain organoid to fuse it to model something more complex or something like that. And in addition to that, I think what is a little different from conventional tissue engineering type of approaches is to think about the spatial temporal regulations we have to manipulate. So for instance, we have a lot of different culture matrix type or factor types to induce a biological assembly process in an organoid culture model. And in addition to that, air-liquid interface culture or sort of agitation, rotating culture, synthetic environments is really important as well to really guide the process of organoid formation process. So I think this sort of very spatial temporal engineering process is really critical in moving forward. In my laboratory, really working on the vascularization initially for the past few years to develop liver bud structures in vitro, and when you transplant into the animal model, we can develop a functional blood vessel just after 48 hours without any manipulation, so that is good. And also my close collaborator, Jim Wells, happy to hear his name in the previous roundtable discussions, but Jim Wells and my Claremont laboratory is really working on making innervated organoid tissues as well, which is remarkable, I guess. And also we are working a little bit towards the hematopoietic interaction because, the liver is the initial niche for the hematopoietic stem cells. So we kind of finding that hematopoietic stem cells is kind of co-developing in this organoid model to form multiple different subtypes in our organoid model. So this is just an organoid histology section really looking like similar to the fetal liver samples. But what I'm going to talk a little bit is about the different complexity. So the previous one is talking about intercellular complexity, but what I'm going to target as the next field is intertissue connectivity, because if you have a defect in the biliary tract, your liver is going to fail because of the biotoxicity. So when you think about making a functional liver tissues, I think you need to think about neighboring tissue connections as well. So over the past few years, Hiro and Ken was really working on pretty hard to develop the connections in an organoid model. So partly inspired by Hans Kleber's movies, we are making a sort of movies to conceptualize our tissue culture model. So we are making anterior and posterior gut tissues in an organoid format and making it as a boundary to form a hepatobiliary precursor indicated by red color. So we actually using the border lines. And by this sort of boundary culture model, without any additional cytokines, we can induce morphogenesis as indicated in these animations. So this is namely an invagination of the hepatic tissues labeled by the PROX1 or HNF4 alpha as well. But not just that, we are really surprised to see the sort of self-assembly or segregation of the multiple different lineages, including pancreas, which is a ventral pancreatic population of biliary tracts, as well as the liver progenitor populations. So having that structures, we can really recapitulate the biotransport pathways. So if you expose a bile acid, you can just visualize the process of biotransport dynamics as well. I know it's a little too much illustrations, but there are some sort of connections like that to really pump out the bile acid structures into this lumen of that. And also, just to confirm the in vivo phenomenon, we are knocking down the HES1, which is a critical pathway to maintain the biliary tract. If you knock out, you're going to see the pancreatic or plastic development as indicated in this movie shows. So not just looking at just movie, we are able to form, for sure, the PROX1 positive hepatobiliary progenitors are developing over time in an air-liquid interface culture. And continued on that, we performed the 60 or 90 days of culture system to really label the liver is really connected to the biliary tract, as well as the ventral pancreatic portion, as well as the duodenum structures. If you zoom in to the liver structures, AFP for sure is labeled in this slide, as shown in here, and EPCAM is a sort of immature hepatoblast marker, as well as more sensitive markers of the biliary tract. And if you look at the panel K, which is the confirm the hepatobiliary connection directly, and also we have a pancreatic segregation as well for the tip progenitors or trunk progenitor, which is a very important precursor for the multiple different pancreatic populations. So we now conclude that very early primitive tissues though, but we are able to form a hepatobiliary pancreatic segregation in our organoid culture model. But moving forward, I think the critical question in this session, particular session, is how we can impact the human medical applications. So, the healthy or disease, we can now induce a human stem cell and to make a tissue replica, and by having that, we can ask the question about the human development. But I think Hans already summarized it beautifully, but precision medicine drug development application is really something meaningful. And also, I'm going to highlight today, but we are working on the transplant application as well. So my talk today is really focusing on the drug development. So maybe you guys are pretty familiar with this statistic, which is talking about inefficiency for the drug development. So out of 30,000 of compounds, you can find the one particular compound which is entered the clinical trials. And not all the compounds is actually successful, and not just inefficient, but we need lots of money to do that. Actually, $600 billion per year in just top 10 pharmaceutical investing in R&D for this sort of drug screening process. And if you look at the phase 2 to phase 3 transition, we have prominent hurdles to go forward into the clinical applications. And the majority of them is a safety concern and efficacy concerns compared to the previous drugs. Indeed, actually, my collaborator, Takeda Pharmaceutical, has significant loss of the diabetic drugs, which is called TAK-875. And this drug was really effective in terms of efficacy, but unfortunately at the phase 3, 1 out of 1,000 of patients is manifesting the cholestatic toxicity, which was the problem for the failure. So Takeda invested 10 years of development and almost $1 billion for this particular drug, but eventually they are losing everything because of the cholestatic toxicity. So we want to model that in our organoid model. So we are kind of developing a more standardized or a more specialized model for the cholestasis, as indicated in this chart shows. So there are multiple processes, and we can store it in the middle process of organ formations, and not just forming a beautifully clonal organoid, but they have a variety of hepatocyte characteristics, not really perfect, not really perfectly mature, but they have the capacity to metabolize some drugs, which is similar extent to the adult hepatocytes in culture. And then we adapted this culture system into the 384 well-based high throughput screening analysis, as everybody working on. So we put the 20 organoid per wells and performing a cholestasis screening by live indicators. So if you become non-fluorescent samples, you're going to see this is something like cholestatic. But if you can accumulate the bile acid into the lumen, you're going to see a non-cholestatic, which is safer drugs. And in general, we have tested over 200 of compounds in 4 or 5 different concentrations to really show that initially the hepatotoxic compounds can be modeled as indicated in this just general analysis. But when you look at the specific compound subsets, so this is the cholestasis indicator, which is a fluorescent bile acid. So if you look at the non-prominent, non-compounds induced cholestasis, is really degrading the fluorescent signals inside the organoid, which is really confirming the clinical trial data sets. And not just that, we can sort out what is the compounds really kind of inducing the cholestasis and identify a couple of compounds, which is really unknown toxic compounds in the clinical trials, really suggesting that organ model can do something about the cholestatic toxicity screening. And now I'm moving to a little bit towards the efficacy screening, which is also the significant concern for the clinical trials. And by looking at the fatty liver example or steatohepatitis example, because the NASH or steatohepatitis is one of the main leading cause for the transplantation. So we need to find the drugs to prevent disease progression into the end-stage liver failure. But unfortunately, there are no any available single drugs for this particular condition, probably because we don't have a very good model to test that. So Rie, former postdoc in Cincinnati Children's, has found a way to do that. So she actually exposed linoleic acid in the middle phase of organoid formations, and found out there are very interesting co-differentiation or co-development phenomenon in our organoid culture system in human iPSC. So not just hepatocytes, but she found out a Kupffer cell, which is a liver-resident macrophage, as well as the hepatic mesenchyme, which is thread-like cells, co-developed from the human iPS cell. So this is not co-culture of different cell types, but co-differentiation model. And this is just immunostaining to confirm some subset of the cells are expressing the CD68, CD13, or some CD11B, which is an indicator for the macrophage. And the lower panel showing the single cell RNA sequencing data just to show the composition of these structures. So majority or 60% is hepatocytes, and there are some biliary cell lineages contaminated in this culture system. But some 30% is hepatic mesenchyme, which is a steroid-like lineages. But more importantly, I think the Kupffer cell is really induced in this culture model. So then she next set out to study the inflammatory or fibrosis process can be modeled or not. So she just exposed a very prominent fat accumulated culture media supplement in this organoid culture model, and just simply initially performing on a single live imaging per organoid to see if we can discriminate the steatosis conditions. And in the left one is just a Z-scan of the confocal imaging per organoid, and the green one is the triglyceride accumulations. You can tell that this is really dose dependent, so steatotic events can be recapitulated like in humans. And not just that, if you continue or persist this treatment, high lipid conditions over time, you're going to see the EMT transition or steroid cell activations. So H and I is really just to confirm the mesenchyme marker is upregulated in response to the fat stimulations. And panel J in this graph, far right, showing the biomarker-based, supernatant-based ELISA detection can be possible to really tell the fibrotic status. And probably, I think this is still preliminary, and much of the pathology is not still model, but I think at least we can detect the early fibrotic response in this culture model. So how is it similar to humans? So we tested a couple of compounds, which is currently tested in the phase 3 for the NASH. And which is namely obeticholic acid. So if you don't really expose the obeticholic acid, so they're going to die over time, as indicated in the bluebird, which is like a Kaplan-Meier survival curve, but it's not really humans, so organoid. So if you expose the obeticholic acid or the mediator, which is FGF19, you're going to see that much improvement in terms of survival. And if you pick up the surviving organoid, you can tell the mechanisms regulating this improvement. For instance, if you look at the loss activation, which is the hallmark for the initial inflammation in the NASH, you can see the massive recovery of the loss accumulations. And because of that, in panel D, this is a fibrosis measurement. It's also improved, as indicated in the far right graph shows. And this is something tells us that human-based drugs testing mechanism can be tested in this steatohepatitis model. So how we can go forward? So this kind of story is already published. So how we can move forward to inform more complex sort of genetic backgrounds. So we test out this by looking at the polygenic potential susceptibility for the NASH. And it is pretty known that there are a number of genetic factors is really defining the NASH. For instance, the PNPLA3 is indicated by number of clinical genomics work aggregating thousands of or tens of thousands of patients' genotype data sets to really tell this is something important for the NASH development. And similarly, TM6F2 or GCKL and BOAT1 is also indicated to involve multiple different processes of lipid processing. But unfortunately, there are many controversies despite there are a number of patients are indicated for genomic studies. For instance, if you look at the TM6F2, Japanese population is kind of controversial. So there are some reports saying similar to the other population, TM6F2 is important, but not really entire study proven that in the Japanese population. There are also therapeutic controversy like dietary therapy is somehow resistant for the PNPLA3 for carriers, but not much really known about the mechanism regulating that on that. So we're currently collaborating with the number of collaborators, which especially with the company providing a direct consumer genetic testing services. So I think this framework is really important for the community. So I just want to present. So DENA is a company providing a direct to consumer genetic testing services. So we have spent almost 3 years in an IRB process or regulatory process to be able to do this study. So we recruit the healthy person with a genotype data sets and identify the most susceptible patient subsets by healthy person subsets by aggregating the different genomic factors. So we taking into account 4 different most prominent factors, and we reapproached based on the consent to obtain the blood samples to be able to form iPS cells. We can only get a biopsy from the healthy person. So we study out from the PBMC to make iPS cells to form a liver organoid to see if we can model the genomic data sets. So this is kind of very preliminary data sets, but if you stratify based on the high-risk patients, based on the polygenic score, comparing with the low genetic susceptible patients population, we can tell the prominent increase in the triglyceride accumulation per organoid, which is suggesting that we can hopefully in the future we can make a sort of human organoid-based clinical trials as a preclinical tool. Just to sum up, so inter-organ connection is, I think, really critical challenge began to be explored, and cholestatic toxicity is able to implement it in a clinical, preclinical level. And steatohepatitis model can potentially inform the GRAS data sets, which is like our organoid GRAS data, to really test the controversial genomic backgrounds in our organoid model. With that, I'd like to thank all my colleagues, especially in Cincinnati Children's, Hiroko Uike, working on the liver complex model, and drug screening for the Takeda-Sila collaboration program, and also funding SOS and my colleagues at Cincinnati Children's as well. Thank you so much for your attention.